Thank you so much. This is actually one of my favorite topics that I've been looking into for several years, so I really appreciate the chance to come and speak to you about it and give you an idea of the conclusions that I've come to and the tools that are available to us, looking specifically at people with type 1 diabetes. As I was preparing the talk, I was doing the traditional slides that we do in the U.S., which includes our disclosure, and I realized I don't have any disclosures related to lipids, but I included them anyway just to give you an idea of what I do have. I'd like to start with a case, and this is actually a very common occurrence in my clinic. We have a clinic dedicated to type 1 diabetes at Ohio State University. And this is a 39-and-a-half-year-old male who presents for a routine appointment. His A1C is 6.5%, so he's doing very well. He's maintained this level for 5 years that I know of. And as we go through and do his screening, his annual foot exam is unremarkable. We review his pump settings, we discuss his continuous glucose monitor data, and then we go through and review his risk of complications. His urine microalbumin screen was normal. Systolic blood pressure is excellent at 116. His last eye exam was within the last year and showed no retinopathy, and his LDL cholesterol is 104. So now the question becomes, should he initiate therapy with a statin at this time? He's not quite 40 years old. I like to begin this discussion before they turn 40. I like to do it in the context of having all of my microvascular screening. And the question becomes, what should we do and how do we make a decision on whether or not he should receive a statin? So I just want to raise a couple issues with respect to estimating cardiovascular risk. And remembering in this case, we're talking about primary prevention, not secondary prevention. And secondary prevention would be in someone who has a documented cardiovascular event or any evidence of any clinical cardiovascular disease. And I listed here some of the things I would look for: an abnormal EKG, heart failure, even chronic stasis changes or documentation of peripheral vascular disease, certainly a history of a stroke also. And then as we look at CV risk calculators, and remember I mentioned the 4 that ACE recommended using in their lipid guidelines, but when I'm specifically looking at someone with type 1, I have to ask the question, does this risk calculator incorporate diabetes? Does it differentiate the type of diabetes? And also, because I think this is important in type 1, does it consider the HDL cholesterol? In other words, if HDL cholesterol is high, is that a negative risk factor in this specific risk calculator? Now, just to remind you of the history of the guidelines, we had the ATP3 guidelines in 2001, 2004, introduced the idea of going below 70 and the non-HDL cholesterol. We then had updates over the years, European ones in 2011, ACE in 2012, then a flurry of them in 2013 and 2014 with this change to moderate and high intensity statins. But none of those guidelines separated out type 1 from type 2 diabetes. Then you move forward to 2016 and 2017, and ESC put out an update last summer which did specifically address the issue of type 1, but generally not in a great amount of detail. And as I've already told you, and I'll come back to in this year with ACE, we did specifically pull out what are evidence-based guidelines for increased risk in the context of type 1 diabetes. Now, I've put on here a number of the calculators you can use and their web links where I could find them. Not just the Framingham, but some of the newer ones, such as the pooled cohort risk, Q risk, I mentioned Reynolds and Mesa. And the question is, do any of these specifically address type 1 diabetes? And the answer is the one I've got at the bottom, which is the Steno type 1 risk engine, actually does. And I'll come back to that one and I'll give you some examples of how it functions in the context of type 1 diabetes. But first I'd like to show you what would happen with some of the calculators we're more likely to use, such as the UKPDS or the ACC-AHA. So when you look at the UKPDS risk calculator, your first thought is, well, why should it work for type 1? It was a type 2 database. So really it shouldn't be accurate for type 1, but you have to ask the question, how well does it perform? And really the answer is it doesn't perform well with type 1, but I'll show you. The components are gender, age, and you see right away the age stratification starts at age 60, 60 to 74 and greater than 74. Diabetes duration, whether less than 5 or greater than 9 years. Smoking, A1Cs less than 7, greater than 7.9. Systolic blood pressure, total cholesterol to HDL ratio, and it does actually incorporate the presence or absence of microalbuminuria. So if you take a 40-year-old, in this case a 40-year-old Caucasian female with diabetes in the UK PDS calculator, remember they don't ask if it's type 1 or type 2. She's got a total cholesterol of 220 because her with an LDL of 85, systolic blood pressure is, that's an HDL of 85, normal systolic blood pressure, no hypertension meds, non-smoker. The calculator says she has average risk and her 10-year risk is less than 15%. So that doesn't help me to know if a 40-year-old female with type 1 needs to be on medication. If you then take that same female and you stratify by A1C, whether it's below 7 or above 7.9, it didn't change her risk at all. If you turn it into a male, slightly lower LDL, total cholesterol, because his HDL is a little bit lower, he still has average risk. So this risk calculator is really not going to answer my question for someone who's 40 years old, much less with type 1 diabetes. I then look at the ACC-AHA, and they do have similar categories. They also factor in race, but only specifying white or African American. They do include smoking status, which is a little bit different, and they separate out total cholesterol and HDL. So if I take a 40-year-old Caucasian female, again now using ACC-AHA, what do I get? She has no hypertension, non-smoker, she has a great HDL, she now has a 10-year risk of 0.5 and a lifetime risk of 39%. So based on her 10-year risk, there's no urgency for statin. But because of the lifetime risk, the calculator actually says she should be on a moderate intensity statin. And the question is really, do you feel comfortable starting this person on a medication when she really appears to be quite low risk, at least at this age and time? If you change it over to a male, his 10-year risk becomes slightly elevated, and his lifetime risk also elevates to 50%. But it's still not answering my question of whether he should start now, because his 10-year risk is only 1.2%, or if perhaps I could wait until he's 45 maybe. And that's what the patient is always going to ask me, well, do I really have to do it now? How long can I wait before I start the medication? So I tried then with this calculator to drop the age down to 30. I mentioned that I usually start talking to patients before they turn 40. My patients with type 1, I start talking at age 35. What about someone who's age 30? Well, it turns out this calculator cannot give me a 10-year risk because it's not able to calculate if the age is below 40. And it does, however, tell me that his lifetime risk is still 50%. And interestingly, it tells me that he should be on a moderate intensity statin, even though it can't tell me his risk from age 30 to 40. And remember, I told you the same gentleman, when he's 40, his 10-year risk was only 1.2. So at this point, I get very frustrated with the calculators, and I'm really not sure what to tell my patients with type 1 diabetes, especially those who are well controlled with no evidence of complications. So the question becomes, what do we have that's specific to type 1? And the major tools that I use are the recommendations from ESC, the European Society for Cardiology, the Steno T1D risk engine, and the ACE 2017 guidelines. So what about T1D in ESC last year? And their recommendations were to highlight the fact that CVD and mortality risks have decreased in type 1, but remain unacceptably elevated, especially in those with poor glycemic control and kidney disease. They recommend intensive management of glucose, management of blood pressure at least to 130/80, and then they address lipid lowering. And their recommendation is very general. Lipid lowering agents targeting LDL cholesterol reduction should be recommended to the majority of patients over 40 years of age, and to those younger than this with evidence of nephropathy or with multiple risk factors. So they're not helping very much there other than saying probably at age 40 you should be starting them on a medication. They did, however, qualify it saying current evidence suggests many patients with T1D over the age of 40 continue to smoke, are still not receiving statins, and perhaps most importantly, have poor glucose control. So they're highlighting the issue that we still need to address things other than cholesterol: glucose control, medical nutrition therapy, physical activity, and smoking cessation. But that's basically the extent of what ASC talked about. So then I went looking in the literature to see what data we actually have. And here I'm just referencing major databases. There is other data. For example, there's a retrospective study of people on insulin pumps showing that they had lower cardiovascular disease. But I was looking for databases that had comprehensive data and prospective long-term follow-up. We have the data from DCCT showing that if you start intensive control around age 20, you have a decreased risk of events 20 years later in your 40s. We have data from the Pittsburgh EDC showing that intensive control does decrease CV events in the long term. And then there's the Steno Diabetes Center in Copenhagen, which is the one I'm going to talk about in a moment. And I just included the Spinning Diabetes database from Denmark because it was used to validate the Steno risk engine. So what the Steno T1D risk engine is basically looking at the cohort of people with type 1 diabetes that are seen in the Steno Diabetes Center. And this is important because their population has been validated as representative of people with type 1 diabetes in Denmark. They analyzed almost 5,000 patients to create this risk engine, excluded people who had previous CVD or no follow-up during that time, bringing them down to 4,300 patients. I do want to mention that the cohort used for this is slightly different from what we have in the U.S. DCCT and Pittsburgh edict, the patients on average are diagnosed at age 14, whereas in Denmark, those with type 1 diabetes on average are diagnosed at age 20. This raises a very interesting issue that I deal with patients all the time. For example, they tell me they don't have type 1 diabetes because they're too old. Well, when you look in these databases, the majority of people with type 1 are diagnosed over the age of 18. And in fact, there's data from Sweden that more people are diagnosed in 1 year over the age of 50 with type 1, or as many as under the age of 18. So it's not a juvenile diabetes, and it's very, very common, with about 2/3 being diagnosed over the age of 18. As I mentioned, this risk engine was validated on another database in Denmark. So I want to show you some examples using the Steno T1D risk engine. And while it doesn't fully answer my questions, at least it's a little bit more specific than the data I was getting from some of the other risk engines. And first I just ran a 28-year-old female. She had been diagnosed at the age of 8, so 20 years of diabetes, pretty typical A1C at 7.5%, not on statins, but LDL is pretty good at 110, and she has no nephropathy. And what this shows you on the left is what the risk engine looks like. When you go on the website, you enter in all these different categories. Maybe I can highlight it with the mouse. These are where you enter in the different information, and it can go in as SI units or as percent for A1C and mix per DL for LDL. But it also asks you if they're normal, micro, or macroalbuminuria. It asks for the estimated GFR. It asks for exercise level and whether or not they're a smoker. And then it gives you, as you see here on the right, the risk. In this case, this person is low risk. And then it gives you the 5-year risk and the 10-year risk, and as compared to someone of a similar age but without type 1 diabetes. So you see, even though she's had it for 20 years, she's got good control, no complications, she's active, and she has very low risk at 1.8, and I believe this is 2.4 for 10-year risk. So really the recommendation would be not to give this person a statin. Then if you give her microalbuminuria, but with preserved EGFR, you have a slight increase in risk, but not much. She's still low risk. And the key here is the preserved estimated GFR. Remember what I showed you in the previous lecture about when eGFR goes below 75. In this case, this is estimated with hers above that level, and so she remains low risk. Now, if you move her forward to age 40, so she was diagnosed at age 8, 32 years prior. A1C is good at 7.5, LDL cholesterol is 110. She has no albuminuria, and I'm just showing you the summary charts here. She's still low risk, but she does have an increased 5 and 10-year risk compared to what it was at age 28. Now you move on to the right, and she's 40 years old, 32 years of diabetes. She's got microalbuminuria with preserved eGFR, and her 5-year risk is still fairly low, around 5, but her 10-year risk is now 10.9, so she's considered medium risk. And then probably you would give her a statin at this point. Now, if you moved her forward and she was diagnosed at age 25 instead of 8, she's only got 15 years of diabetes. She's very well controlled. You can see the presence of albuminuria on the right with preserved eGFR still has her below 10% on 10-year risk. So duration of disease was playing a role there. But again, the big difference was, the duration of disease plus the microalbuminuria. If you now change her to a male, go back to a diagnosis at age 8, so 32 years of diabetes. In the absence of nephropathy, he's low risk. When you give him microalbuminuria but still preserved eGFR, he becomes medium risk. So this is someone that you would then begin to initiate onto a statin. If you decrease the duration of disease down to just 15 years, still a 40-year-old male, he's now medium risk with the microalbuminuria despite preserved eGFR. So the question becomes with my patient who was almost 40 years old, even with his duration of disease, whether it's 15 years or 32 years, because my patient had no albuminuria, he stays in the low-risk group. And he's smart, he's going to run this calculator for himself, and he's going to come back to me and say, I don't think I need that medication. And I'm going to have a hard time arguing against him. So the things I'm going to do is talk to him about other markers, things like hsCRP. I do a lot of coronary calcium in these patients, like the one here on the left, because if they have a high coronary artery calcium score, I am going to argue for medication. So what we learned from the STENO-T1D risk engine is that duration of disease is important, that any amount of albuminuria does increase risk, but it can be attenuated by preserved eGFR. If the eGFR is still 90 to 110, they're not too high a risk. As soon as it drops below 75, that's when they become medium and high risk. And so really what I learned from this database is that it's the decrease in eGFR that I really need to watch closely, and it's a major predictor of risk. Now I'd like to go back and remind you about how the 2017 ACE lipid guidelines address type 1 diabetes, reminding you that this is a full committee who put together, we had a task force starting just over a year ago, and the guidelines were published this year in Endocrine Practice. And reminding too about that it's a clinical practice guideline, formal recommendations, grading of evidence, both in terms of for the recommendations and the citations. And then in terms of the questions that I've already addressed, I want to go back to my fourth one, which was the question of how does type 1 diabetes affect risk? And remembering the categories, especially the extreme risk, where our target would be less than 55. So coming into diabetes, again, what ACE recommends is that individuals with type 2 diabetes should be considered as either high, very high, or extreme risk. Again, you individualize to the person. But again, back to this issue of type 1 diabetes, what are the factors that we can pull out of the literature, the trials that have been done, primarily DCCT, Pittsburgh EDC, and then the albuminuria studies, and also the meta-analyses and systematic reviews. And as I said, what we found was the presence of albuminuria predicts risk. If you have later onset type 1 without nephropathy, but do have a great duration of disease, that predicts risk. So this 15 years of disease is more important when the person is diagnosed as an adult. And that's why I wanted to highlight the 32 years versus the 15 years. Someone diagnosed at age 8 doesn't automatically become high risk when they turn 23. But duration of disease is a factor as they get older. But what does come out of the literature, and I really don't like the way we worded it, which was initiation of intensive control more than 5 years after diagnosis. Because the authors described it as if you don't have their A1C below 9 by 5 years after diagnosis, you probably should put them on a statin. So think about it that way. If it's been more than 5 years and you're not getting them under control, regardless of age, you probably should put them on a statin. And then this is just reminding you of the albuminuria data with that threshold of 75. And also reminding you in terms of the ACE recommendation number 10, here in the middle, annually screen all adults with type 1 or type 2 for dyslipidemia. And then also reminding you of the categories. So type 1 doesn't automatically put you at extreme risk. It could be high, very high, or extreme. But some people will actually still be low risk as long as they have no microvascular complications, are well controlled, no metabolic syndrome, and not overweight or obese. So this is just the summary of the lipid of the targets, again giving me a chance to remind you that we still include non-HDL cholesterol, that we recommend triglycerides below 150, and that we do recommend consideration of ApoB levels. And then, again, going back to treatment, still lifestyle changes are the most important and the foundation of your therapy. And what do we do in terms of the medications available to us? We pick the dosing not just based on what our target glucose is, but whether or not the person is agreeing to take it, if we think we'll tolerate it. I may start someone with a very low dose of pravastatin with an eventual goal of getting them to something like a Atorva, Rasuva, or pitavastatin. So coming back to my case, he's 39 and a half years old. He's not yet 40. He's well controlled. He has no microvascular complications. Just quickly give me a show of hands. How many people think he should be taking a lipid-lowering agent at this time? Would anybody put him on a lipid-lowering agent? How about anybody would put him on it the day after he turns 40? One person over here would. And I'm not going to fault you with it because 40 is really where it starts to become that gray area. He has no complications, but he's starting to move into the medium risk category. Again, I'm going to individualize it, and sometimes it takes me several years of talking with the patient to convince them, which is why I started at age 35. The challenge is, if you are going to start him at this point or at age 40, what should his LDL target be? Should it be below 100 or does it need to be below 70? Someone like him, I'm probably going to start with targeting below 100. If he's not going to start a statin now, when should he? And the answer I'll give you there is it's an ongoing conversation he and I have at every visit, and incorporating into that especially is urine albumin screening, maybe more frequently than once a year, especially if his A1C starts to rise. So just to summarize, what I wanted to highlight is when you're addressing cardiovascular risk, type 1 diabetes does not equal type 2 diabetes. Type 2 diabetes is a CHD risk equivalent, type 1 diabetes is not. But consideration should be diagnosed as an adult with duration more than 15 years. If they have more than 2 or more major risk factors, especially albuminuria, stage 3 or 4 CKD, or they're still uncontrolled at 5 years after diagnosis, maybe they weren't controlled in the past and they've been poorly controlled, you're not optimistic they're going to get under control, go ahead and start them on therapy. And also insulin resistance with metabolic syndrome. So just to finish, again, I included my email address here. I put the link to the ACE lipid guidelines, and again, I put on the link to the Steno T1D risk engine. Thank you very much.